Hello, I'm Dr. John Kruse, and welcome to today's question and answer session hour. So a reminder that the information here is presented for educational purposes only. I try to make sure that what I'm saying is true and accurate and use my training as a neuroscience and my 30 plus years as a psychiatrist to assess what I'm saying, hopefully is true and accurate. But again, I'm not making any specific medication or treatment recommendations. The time today is open to questions on the two videos I released this past week. One was a re-release, or other topics on ADHD or other mental health topics in general. And before I jump into other topics, I also have sent out to the people who subscribe to this channel and notice about it. There's an ADHD Entrepreneur Summit designed to provide help for people who have ADHD who are trying to make it in the business world. I have a talk on using scheduling, and schedules can be your friend. There's, I think, 30 to 40 different speakers. It is free, and the link will be, I think it's already on my YouTube channel. That's starting April 7th and 8th. I'm in the pre-recorded part that's on the 8th. So I'll summarize the two videos in about a minute or two each and then jump into questions. The two videos, the new video was about Trump derangement syndrome. It was sparked by Minnesota state senators proposing a law in Minnesota that would enshrine Trump derangement syndrome as a medical mental health condition. This is ridiculous in that the legislature has no authority to create mental health diagnoses. Two, we already have a diagnosis called delusional disorder, which covers much of what Trump derangement syndrome is trying to address. And three, the clear use and attempt to use TDS, Trump derangement syndrome, is as an attack to silence people. It is not there to promote understanding or to promote treatment or health of individuals. So it doesn't even on the surface actually qualify or make sense as a mental health condition. I'm happy to talk more on that, or I'm happy to avoid that if people want me to steer away from that topic. The second one was on antidepressant withdrawal syndrome. I'll get a little political here because there is actually a small cadre of researchers and followers who have made a big business out of claiming everyone suffers from antidepressant withdrawal syndrome, that antidepressants don't do anything good or positive at all. They only cause problems when you try to get off of them, and that most people have these problems and that they are serious and the medical community has hid it or tried to ignore it. And the actual data does not support any of those claims. Substantial numbers of people can stop these drugs cold turkey, not that we ever recommend it, without much of a problem. The vast majority of people who do have withdrawal syndrome symptoms are mild and short term. That does not mean, I'm not trying to diminish, there are some people who have suffered significantly and suffered for a long time, but that is not at all the norm. Those are outliers. And there is some good research done, I believe it's in the Netherlands primarily, that even people who've had bad withdrawal reactions, if you taper them slowly enough and gradually enough, they can successfully, without huge amounts of physical or psychiatric syndromes, get off the medications. So those are the two videos, and I see, welcome Dennis, or hello again, Dennis. I see Dennis has a question and a good one, and that's how do you differentiate between discontinuation syndrome and recurrence of symptoms? So I wouldn't even call it discontinuation syndrome. I would use the term withdrawal, because the term withdrawal is implying that there are discontinuation can be ambiguous. So you could have discontinuation symptoms as a symptom of just stopping it, and that would be a return of the original symptoms you were treating. So withdrawal syndrome in antidepressants, there's a couple, the big factors are time frame and what the symptoms are. So with antidepressants, and we're primarily talking about SSRIs and SNRIs, it's not that other antidepressants can't cause withdrawal problems. They can, but those are less common. So in terms of time course, if it is happening within the first 24, 48, or even a week after stopping, but most commonly they start showing up pretty quickly a day or two after stopping, it is almost by definition withdrawal symptoms and not recurrence of the benefits the drug was having. And for that, the rationale or claim for that is that almost everyone takes a long time to respond to these drugs, and the research the other direction is also pretty clear. Most people, if they're going to rebound or fall back into their depression or anxiety, it takes them many weeks to months, a few months to fall back. And that's because for helping with depression, these drugs appear to have an indirect effect. So their direct effect on reuptake of serotonin happens immediately. The indirect effect of how that helps alleviate depression or anxiety is a set of indirect, slow-acting effects. It's often compared to an assembly line that probably involves making new proteins, probably involves how cells are communicating with each other, may even involve manufacturing, creating new nerve cells. All of those processes are things that take a long time to get geared up and going. So it's like an assembly line. When you're starting out, you need to give the assembly line people a clear and consistent message. Yes, there's going to be demand for this product. Yes, you need to get this up and going. And regularity, how consistently you take antidepressants in the first few weeks, is one of the best predictors of how quickly you will respond, or even if you will respond. On the other hand, there's a body of data, and primarily comes from studies of sexual side effects with SSRIs, where one of the most common approaches is taking a drug holiday. So this is after you've been on the drug for several months, stable and getting benefits. What we know is that most people can go 1 or 2 days, at least a week, without their medication, without falling back into depression or recurrence of their anxiety. That brief break does allow drug levels to drop. It does allow serotonin reuptake action to be diminished, but it doesn't interfere with that long assembly line process of making proteins and, again, changing how cells communicate and maybe even making new cells. So time course is one factor. The other with the antidepressants is the symptoms themselves. So the classic symptoms of SSRI withdrawal, the one that's diagnostic for it is an electronic feeling zap that's often experienced the back of the head, sometimes up and down the spine. People describe it as not painful, but like a sudden startle shock. Again, that is very rare with other medications as a side effect or as a withdrawal effect. It's very classic for SSRIs. The majority of people who have withdrawals, at least in the formal studies, don't have that as a withdrawal syndrome. But when it's present, it's almost diagnostic for it. The more common withdrawal side effects are nausea, weird tingling in fingers or around the mouth or face particularly, readily crying, and that needs to be separated out from falling back into depression. So other than the crying, which could be a depressive symptom, nausea and I'm just blanking right away. Nausea and other physical side effects were not part of the symptomatology to begin with. So when we're talking about withdrawal from other drugs like stimulant drugs, then it can be harder to separate out what is a withdrawal syndrome and what is the recurrence of symptoms, because many people have withdrawal reactions at the end of each day, particularly, or the end of each dose with an immediate release form of a stimulant. And that can be 3 different dimensions. It can be a crash in mood, it can be a crash in energy level, and it can be a crash in executive functions, concentration, focus, organization of thoughts. And those, I'd say many people can have, we call it a withdrawal symptom if you weren't dysphoric before and fall back into a clearer, sadder, more distraught place than you were to begin with. If energy was okay before taking these, and then suddenly energy is crashing to a lower point, that would be classed as a withdrawal or discontinuation syndrome rather than a reemergence of symptoms. So to sum up again, the time course of when symptoms appear and the nature of the symptoms is what we use to separate out from what we call a withdrawal from what is a discontinuation. Hi, Max. In the Trump derangement syndrome video, you mentioned that you would be in favor of major revision of the DSM. What would some of those changes be? So I will speak with a broad brush. So I think the research domain criteria, so National Institute of Mental Health and other organizations, because we've made such, I mean, we've learned a great deal about the brain in the last 2 decades, and I won't say there have been no changes or improvements in mental health care treatment. There absolutely have been, and many of those have been life-saving. But clearly, we have inadequate treatments for lots of people and an inadequate understanding of what's going on. So the research domain criteria is urging researchers to, rather than focus on conditions that are in the DSM, like depression or schizophrenia or bipolar or ADHD, to look at certain functions of the brain, like the ability to direct your attention or the ability to regulate your emotion or a surplus of sad and negative emotion, and to try to understand the neurologic brain-based structures that are involved in creating that phenomena and what seems to be going awry in people who have either problems, deficiencies, or poorer control of that function. And although the domain research criteria says they're explicitly not trying to supplant the current diagnostic system, it's pretty clear that it's leading in ways where if we rethink about what's going on, we will be restructuring how we call things. So one of the biggest sweeping things, and I've talked about this before in terms of ruling in or ruling out, most of the DSM, pretty much every single condition, at the end of, after they list the symptoms that are characteristic of it, they said, and these symptoms have to be not caused by any other condition. But if you look at that at the surface, that becomes a circular, potentially non-ever figuring anything out. So if let's just look at depression and ADHD. You can have both. You can have one, you can have the other, but let's say you have troubles concentrating, distractibility, low motivation to start or complete tasks. That could be coming from either. But by the DSM, it makes it really hard to label it as one or the other, because you could say, you have all these symptoms, but maybe they're attributable not to your ADHD, but to depression. But then if you try to give the person a depression diagnosis, then how would you know that those exact symptoms are from depression, not from ADHD? I mean, you can't have two things that are dependent on mutually ruling each other out. You need additional factors to sort out what's going on. So I think a ruling in is much more reasonable. You can say, this person has features of ADHD. We may even be able to say these are a direct result and secondary to their depression, or that they had them pre-existing and are clearly not secondary to their depression. So I think that's maybe part of a halfway step towards revision. So that's where I'll leave that. So Max is also forwarding a question from the Reddit forum. So that's under subreddit Dr. John Kruse. So current dealer asked, I felt very cold, shivering, trembling, cold hands, feet from Vyvanse. But if I take it with the calcium citrate tablets, no issues at all. I noticed this before with coffee. So some of these symptoms are likely, so the drugs that affect norepinephrine have effects not just in the brain, but also in the body and the periphery. So they can contribute to tremor. They can contribute to constriction of the tiny blood vessels in fingers or other parts of the body, which if you shut down the little blood vessels, then you're going to feel cold there, cold hands and feet. why just having more calcium available in terms of would resolve that? I mean, yes, some of what's going on is involving calcium influx, but most people aren't suffering from a shortage of calcium, but maybe this individual could be. And again, experiencing these same effects with coffee. Again, coffee does have some sympathomimetic, mimicking the sympathetic nervous system, that norepinephrine-based clamping down on blood vessels, tremor issues. So Mr. AKA said, I've been tapering fluvoxamine recently and developed flu-like withdrawal symptoms. So thank you for pointing out some of the ones that I were forgetting that are classic SSRI. What I usually describe to people is it's flu-like symptoms, but almost always without the temperature fluctuations or fever. So it can be headache, it can be muscle ache, it can be nausea. So those are common SSRI. So Mr. AK points out that what he thought had been Luvox withdrawal symptoms actually turned out he did have the flu or some other infectious condition, and now his coworkers are sick. So again, in my experience, I've never seen, and I haven't seen any reports that include temperature, fever fluctuations as part of SSRI withdrawal. So that is a often critical or useful tip-off. If you're having all these symptoms and have a fever, think more likely that you have a cold or infection than a simple withdrawal. And just another note in passing that of all the SSRIs, Paxil seems to be the most likely, but Luvox is also moderately high because Luvox's half-life is substantially less than a day, so it's leaving receptors more quickly. Most of our other SSRIs have an effective half-life of about a day. Prozac, fluoxetine is substantially longer, closer to 10 days to 2 weeks, so withdrawal is less likely with that, but not impossible. Hello, Brian. I've seen your name from some of the comments on videos. Hello. Beth asks, do I have information about titrating guanfacine? Teenage son has been on 1 milligram for 3 weeks and 2 milligram for 2 weeks, but not seeing much difference because every other medication, as far as cause side effects, are happy to take it slow. Is this necessary with guanfacine? How long roughly should one wait before a dose increase? So two different factors when we're titrating up on drugs. One are side effects. So if someone's having side effects on a substance, it's almost always a good idea to pause and let them become either diminish completely or disappear completely or diminish substantially. That doesn't sound an issue here. Again, I'm not making a specific medical recommendation. These are general information. With guanfacine, most of the studies and most of my own clinical experience suggests it can take 2, 3, 4 weeks to see what effect a given dose is having. And again, part of this is because, again, even though guanfacine, like many of our other drugs, is having direct biochemical immediate effects, most of the good things it seems to be doing are involved in synaptogenesis, the creation and building of new synapses in the prefrontal cortex. That takes time to happen and gear up. So my recommendation is to usually sit a minimum of 2 weeks at a given dose before going up on guanfacine, and more often a full month before we're sure we're not seeing any benefit from a given dose. The frustrating thing is that can be a long time, particularly if you're need to go all the way up to 4 milligrams to get a benefit. That could be, potentially a third of a year you've spent. And particularly if you're used to seeing the effects, good and or bad, of a stimulant medication happening within a day, that can be hard. It can be hard, particularly for someone with ADHD who's not patient. So it's not terrible to go up more quickly. The downside potentially is you might wind up on a bigger dose than you would otherwise. And the other thing I would point out from my own experience, I've seen very few people who had a response to 4 milligrams who had no response to 2. So if you're absolutely sure you're seeing nothing, Then I may titrate up a little faster, going from 2 to 3 to 4, just to check that we're not missing something. But if you've been a month at 2 milligrams and you're not seeing anything, I'd say you may well have a benefit more, but it's moderately low likelihood. So Max is forwarding another comment or question from the Reddit channel by Solid Try. She says she's a woman in her early 40s and recently tried meds for ADHD. She's also a runner and ran a few half marathons. When I ran on meds, my heart rate increases a lot. Any suggestions? So all of our sympathomimetic medications can not just increase blood pressure and cause vasodilation, they can also increase heart rate. Again, I can't make specific medical recommendations. What I would say is that one potential downside of all the modern fitness watches is that many people tend to fixate on the numbers that are being displayed and rather than how they are feeling. So I would, in general, recommend people to pay attention to if you are not feeling overstressed, if you are still able to run at close to the same pace you were running, transient increases in blood pressure or heart rate, particularly during exercise, are normal and not particularly worrisome or dangerous. If it's preventing you from achieving the levels of speed or distance that you were able to before, that would be more concerning. There are certainly medications like guanfacine that target ADHD that may actually help lower blood pressure. Has been studied more, but may conceivably also decrease the heart rate elevating effects. But my biggest message here, and I'm a runner, I've finished 100 marathons, have injuries now, and I'm not currently running, so I can relate to wanting to get out there, and I certainly approve of running as a good exercise. Sorry, you're welcome, Dennis. So Abnav Jain is writing in from the Netherlands. Diagnosed with ADHD 13 years ago, but finally decided last month to start medication, and my videos helped. So big thank you. So thanks. That's that is the reason I'm doing this, is that I feel I learned a lot in 30 years of working with people and have some ideas, some of which are other people can articulate well, others which I don't find other people saying at all. And particularly, and it's at least the second study that's come out on this topic, a recent study showed that more than 50% of the TikTok videos about ADHD contain significant misinformation. So there's lots of misinformation to counter out there. There's just a lack of information, particularly relating to the neuroscience that's explained in a simple way. So I certainly enjoyed helping patients in the last 30 years. I have some that I've worked with almost 30 years, but I've been cutting back on my clinical work because my hope was to help a broader number of people in a little bit rather than a small number of people in a bigger way. So Beth asks, what could be a good non-stimulant medication option to try which helps with ADHD emotional management and racing thoughts? So to my knowledge, the most extensive research on helping with emotional regulation has been work Russell Barkley and others did a few years back, looking at the stimulants and showing they have a clear-cut benefit. My clinical impression, again, I don't know that there's a lot of research on this because emotional regulation management has been an understudied realm of ADHD research, particularly because it's not in the DSM as among the target symptoms. So I've certainly seen people on bupropion, Wellbutrin. I've seen people on Cymbalta who felt that one of the things that those medications helped with was emotional volatility and reducing volatility, helping regulation, and racing thoughts can be helped as well by those. Simple Life asks, are they using the term derangement when in actuality it's just passion? Seems like we could label people of any political view who disagree passionately as deranged. So what's funny is, and I wish I had the exact wording right in front of me, in the Minnesota Senate legislature's definition, they claim to be specifically targeting or describing people who were normal beforehand and who became so paranoid or hysterical or upset about Trump that they were unable to differentiate between legitimate policy concerns and the frame of the word was something like the psychic problems of Donald Trump. I mean, so the interesting thing in their wording was that they were actually directly acknowledging that Donald Trump has significant psychiatric symptoms. So their claim is that these people, and I've seen some online, I've seen some in people who are so enraged, so upset that they are just screaming about everything Trump does. However, most of the complaints, arguments I've seen against Trump are specifically targeting his policies, and there are a host of rational, logical reasons to complain about, be abhorred, feel that these policies are abhorrent, and they are not conflating his mental health issues with the policies. Or they are specifically discussing whether he is fit and competent to be president of the United States, which I think is a topic that should be discussed in more detail than it is, and that they're not confusing it with policy concerns. So their own claim of how the term should be used is not how they're using it, and it's used very classically in a shoot the messenger, try to shut up, stifle, stigmatize the person who's talking, rather than acknowledge they may have legitimate reasons to be voicing what they're voicing. So there's so many questions coming in that the list is getting blurred. So Abhinav has an ADHD question. He started 18 milligrams methylphenidate XR. It worked great for mood and executive function, but had to stop on day 4 because suddenly anxiety episode and noticed tinnitus on day 6. So with anxiety, I mean, if my recommendation is if anxiety is mild or if it's decreasing, then that's a sign that it's likely to continue decreasing. If it's increasing day to day, that would be a reason to try to back down. 18 milligrams, I mean, it's a Concerta-like analog, is probably the lowest dose on that product. And if it's using an osmotic delivery system, then you cannot, well, you can physically, but you should not break those pills in half because it completely destroys the osmotic delivery system. So it's no longer slow release and the drug is not evenly distributed in that. If it's just a normal, more conventional slow release product where the slow release mechanism is the matrix that the drug is locked in, and many generic Concerta do use that, then you actually can break it for a lower dose. I'd be more concerned with tinnitus. Some people pronounce it tinnitus, but that makes it sound like it's an inflammation of the tin. The itis meaning inflammation of, it's tinnitus. Both are acceptable. Tinnitus can be a reaction to any of our medications and tends to be ongoing. I mean, some people have it and then it goes away, but I would be more concerned there that may be a side effect that doesn't go away or improve. So maybe even starting so anxiety, a single episode, my best recommendation is to be aware being on a stimulant does increase the likelihood of an episode of anxiety. And I have talks here on panic using cognitive behavioral approaches, which I think are far and away the best approaches for dealing with severe anxiety. So again, I can't make specific. So this individual is now on 30 milligrams Vyvanse. That's not working as well. And should they retry methylphenidate or atomoxetine? So again, all of these drugs do have some potential for triggering acute anxiety. In 30 milligrams dexamphetamine is only about 10 milligrams of dextroamphetamine. That should be roughly comparable to about 18 milligrams of methylphenidate, but different people's bodies may not relate to them the same. So the person mentioned it's not working that well, and it's not clear whether that's because of side effects, which would be a reason not to go higher, or because they're just seeing less benefit. If it's less benefit, it may be reasonable to try a slightly higher dose, even though the thinking is that the equivalent is you're on a higher dose. So that's hopefully information that's useful in decision making. So Dropneck asks, if a patient was taking a Concerta but had inconsistent results, some days it doesn't work, others it works great, what would be your approach without changing the med? So one is that most normal humans that aren't AI-generated robots have substantial fluctuations in their attentiveness and their ability to do simple tasks, to catch their own mistakes, to fluently read or talk or write. People with ADHD tend to have even more extreme fluctuations. With some days they're really on target and things are going great. Some days they're just wake up and they know, forget it, nothing's going to work. So this is in a pre-medicated or unmedicated state. There's normal day-to-day fluctuations. So some of my approach is usually reminding and explaining that to people. One of the biggest variables affecting consistency is how well you slept the night before. And sleep is problematic in a vast majority of those with ADHD. And one of my claims, I think I made it in the Huberman interview, is that unless you get sleep under control, dealing with ADHD is going to be a much bigger battle than it would otherwise. It doesn't mean sleep is going to solve everything for everyone, but without solving it, that's going to cause bigger problems in day-to-day fluctuation. So one of my approaches would be to focus on getting, and again, it's not just sufficient sleep, it's getting regular sleep. Circadian rhythms are an important variable here. Other approaches may be to being more regular about the timing of the medication. So that can certainly exacerbate circadian rhythm problems. It can exacerbate fatigue at the end of the day, or not being too revved up and not being able to sleep. So making sure that the timing of the medication and the sleep-wake cycle are both stabilized, I think, are important. So Max mentions that in the Trump derangement syndrome video, I mentioned internet gaming disorder, seeing as how games in general have always faced a conservative backlash, like Dungeons and Dragons back in the day. And the video games have always been the target of accusations of corrupting youth and leading to violence with no evidence. How can one not be alarmed by the attempts to pathologize internet gaming? So one is I would differentiate, and I do this clinically a lot, there's a difference between being concerned and alarmed, I'd say, and I deal with this a lot in helping people with anxiety disorders. Alarmed means you've come to the conclusion this is bad, wrong, and a danger, a threat. Concerned means there's potential for something to be. So someone waiting for their mammogram assessment to evaluate what lump is going on until you know that lump is cancerous or some other dangerous problem, it does not make sense to be alarmed. It makes sense to be concerned, and you will get further information as to whether to be alarmed at some other point. So the inclusion is, the people who are working on advocating for its inclusion are well aware of the history of pathologizing video gaming and are seeking to include it because there is some segment of people where it's not just the amount of time, but which has some correlation, but they are very careful that it's not just spending a lot of time doing it. You absolutely need to be neglecting other parts of your life. You need to have wanted to stop quitting and have trouble doing it. You need to feel negative emotional states when you are in the absence of this. So on a multitude of biochemical and behavioral levels, to me, the evidence is fairly compelling that internet gaming disorder can be a addictive-like phenomena. And I do think, again, that there are gambling disorder is another one. That doesn't mean everyone who bets on the Final Four in the current basketball games is a gaming addict. But I think there are some people who gambling or gaming is ruining. There are cases of people who have died from dehydration and other problems stemming from not getting up to go to the bathroom or eat or sleep for prolonged periods of time, multiple days in a row. So, but yes, we should be concerned that people will misuse these diagnoses, that people will use it to label or pathologize people who are engaging in behaviors that they don't like. So concern, yes, but alarm, I would say, not yet. If we found that they were abusing it, then there's cause for alarm. So again, the distinction would be, like in this day and age, is the Trump administration abusing its executive order powers? Is it defying judges? Absolutely unverified or verifiably, it is doing so. And is it acting in ways that violate the Constitution? Is it working to silence individuals? Those are undeniable, verifiable, repeatable, consistent facts. That is reason for alarm, not just concern. Sorry to politicize, but the world is dealing with probably an inflection point as to whether and I'm not saying all the old norms were good norms, but if you want to change it, go change the Constitution. Don't just break the Constitution. So Brian asks, question, what are your thoughts on making the stomach more basic as opposed to acidic to increase the effectiveness of Adderall? For example, some take antacids before Adderall. So I do have a whole video on stomach acidity and stimulant medications. So there is some effect of acidification or making them more basic. Many people don't notice a profound effect. Some do and are more sensitive. So I'll refer people to that whole video. I'd say more often than not, I've seen people who didn't observe effects, even when they were trying to generate effects. And if you are worried about effects, a medication like Concerta, which has an osmotic delivery system, so it is more affected by osmolality than pH, and much of the delivery of the drug and absorption of the drug is happening beyond the stomach. So the further you get away from the stomach, the further into the intestines, the less an impact of however acidic your stomach is. The smaller the impact, the further along you go. So a drug that's delayed longer and is being processed more in the small intestine and very little in the stomach is going to be less likely affected. Mr. AKA says SSRIs can mess with verbal recall due to action at serotonin 2C. Is there evidence that a serotonin 2C blocker like fluoxetine avoids the problem and could help ADHD, since serotonin 2C inhibits norepinephrine and dopamine release? So what I can say there is there have been a number of studies looking at the effects of SSRI on ADHD. And to my knowledge, and including some that looked at fluoxetine, to my knowledge, none of them have found any beneficial impact. This is in contrast to some of Daniel Amen's writings, who, depending on which volume, has 7 or 9 or 13 different variants of ADHD, some of which are responsive to SSRIs. Other people haven't been able to replicate his ability to so nicely separate people into these different categories, and it may well be concomitant depression or anxiety that's being treated and helped. So I'd say it's conceivable, but I just don't know that we have much hard data on the question Mr. AKA is asking about serotonin 2C receptors and the effects of SSRIs. So James Alexander asks, have I clinically seen differences in patients between the different generics for Strattera? So again, I use Strattera atomoxetine so seldom that my sample size is pretty small. And by statements and other talks, I'd say the highest incidence of problems with generics has been in drugs where we're mostly looking at immediate effects, such as the benzodiazepines or the stimulants, where the timing of release, how quickly it's going there, not just the total amount released, may be a factor. So conceivably, different formulations of atomoxetine, even though, again, they should be meeting FDA criteria, but there's a fair amount of slop of essentially close to 25% plus or minus. So it's conceivable that people would have, that if the drugs are entering the body at slightly different rates with different formulations, you could clinically be aware of that and experience more or less effects. Some benefits from atomoxetine for ADHD do seem to be not just its direct norepinephrine effects, which are quick, but maybe slower effects on NMDA receptors in the brain, and those would be less likely to be affected differently by different generics. Wendell Elatar says, according to a relatively recent study, he thinks it's a Swedish one, said computer gaming is pause. I think it's implying, so there is a computer game that is FDA approved for, I'm going to blank on the words, I don't want to say treating ADHD. The thing to be aware of is the FDA's consent or stamp of approval for non-medications is very different than medications. So for medications, you have to prove for a new drug that you work at least as well as what's out there and that you're not causing major problems. For videos and devices, essentially, and I'm not going to get the wording exactly right, you have to prove that it doesn't cause harm and that there's a reasonable chance that it may be helping some people. So yes, there's some aspect. We can look at reaction times. Practicing video games does enhance that. There are other forms of attention that do seem to be strengthened by practicing video games. How well that translates into real world functional benefits is less clear. So there is a video game that's designed to, and it was planned by researchers at UCSF who are well-versed in ADHD and the brain and know what they're trying to do. And so specific program game was designed to enhance or benefit people with ADHD. So it's clearly the case that not all gaming is good, or not all, that's not all good, it's not all bad, but there is some fairly substantial body of literature that a strong correlation between the period of time spent on some of these tasks and traits of impaired ability to sustain attention, a need for constant stimulation, a whole host of symptoms that seem to overlap closely with ADHD. So James Alexander asks, do I believe social pragmatic communication disorder is a different disorder than autism spectrum disorder, or can its criteria be seen as a core symptoms of autism? So I do not know what the formal definition of social pragmatic communication disorder is. It's not in the DSM. I don't believe it's in the ICD list either. And an interesting study that was just released showed that when clinicians are making autism diagnoses, and this is looking at medical health records and what shows up there, it's far and away they are relying on unusual, repetitive, stereotypical behaviors and narrow interests, and much less on restricted social comprehension or communication issues, which is a hallmark and central part of the definition of ADHD. So, I mean, it sounds like this proposal is trying to carve away the core component of autism spectrum. I do have a talk on autism spectrum disorder and differentiating it from ADHD. There is considerable overlap, but there do seem to be substantial. And there was another study released just this week showing different, in general, or not all completely separate, but there are different patterns of neural activation or inactivation, different strengths of circuitry in the two conditions. So, and asks, what's my view on the removal Asperger's syndrome? I'd say rather than explicitly removed, I mean, it's still mentioned as part of the autism spectrum. I'd say to me, I mean, it was not ever a diagnosis that I saw being used in a disparaging or stigmatizing way. Whether it's more useful to have it clear that there's a spectrum of autism disorders, or just as there is a spectrum of ADHD disorders, which we're not currently calling a spectrum. I think we are moving slowly, but away from the DSM categorical definitions, and it's not clear what will replace it. Yep, so getting back to the question about someone who had a good response to 18 milligrams methylphenidate, slow release, but had some panic and some tinnitus, and whether 10 milligrams immediate release would be a good compromise. I'd say it's certainly within the realm of reasonable things to contemplate trying. And again, that's certainly something to discuss in more detail with your personal treatment team. So Windolf Alatar is pointing out, getting back to the gaming issue, that Minecraft was specifically mentioned. I don't know if it was specifically studied, as it simulates constructive cooperation online. And I'm looking. So Jim Rowe asks, what are your thoughts on drugs like phenylpiracetam or non-pept to treat ADHD? So no Nuopept. It's one of the questions you've been asked a few times. It is on my list of substances to study in more depth, so I can give a talk on it. I'm just unaware of the research, and part of it is that it's a substance much more widely available in Britain and the EU than in the United States. So I won't comment because I don't have any useful information, but you're asking about it just boosted it up a little higher on the rather lengthy list of things I can talk about in the future. Ryan asks, in my Wellbutrin video, I said that seeing the effects for mood can take a while. Meanwhile, ADHD, it isn't uncommon to see some symptom relief right away, as it helps some executive functions. Ryan started at 150 XL and it's not feeling anything, no side effects, but no noticeable benefits. Is this an indicator it's too low a dose for ADHD issues? Or could I still see benefit from this dose if I wait longer? So my experience clinically and what I would say is that it's likely that 150, and again, getting back to the person who mentioned there is day-to-day fluctuation, which is why to never take a single day of a medication as a perfect encapsulation. But if you've had 3 days at 150 and you're not seeing anything and you are taking it primarily for ADHD, even if you're taking it primarily for mood or cigarette cessation treatment, I would say in general, again, this is not specific recommendation for anyone out there, but in general, I don't see any value of keeping someone at longer at 150, since we know that that's not usually an effective dose for depression. And if you're not seeing, if you're not seeing benefits for things that should be responding quickly, then it's not likely to be effective at that dose. So yes, in general, in a situation like that, I would encourage going up to 300 is the next step. That's a common dose for titrating Zyban, which is the brand name used for and FDA approved for cigarette smoking cessation, is a week at 150, and then at the end of the week, go up to 300. So Anna's Mesamez, as you can, I think they're spelling heal, not hell, from ADHD, or maybe they're saying both, that ADHD can be hell. So I would challenge that most people with ADHD, most people have a strong genetic component to it. It does involve altered brain circuitry. Some of that may be subject to neuroplasticity and positive realteration, but far and away, most people who have ADHD in adulthood, young adulthood, have it for the rest of their lives to some extent or another. Many lead good, fulfilling, wonderful, creative, exciting lives. So if that is what's considered healing from it, great. And maybe I should just stop because it's not clear if there was a question there or just a comment or what they're referring to. So James Alexander asks, do you think the shift away from a categorical approach to disorders toward a dimensional approach is good or bad? What are the downsides of this shift, if any? The good thing is that I think it more closely reflects reality. So absolutely on personality disorders, absolutely with ADHD, absolutely with many of our conditions, they exist on a spectrum of severity, which means a categorical decision of yes, you have it, yes, you don't, no, you don't, is making an arbitrary decision as to whether 5 symptoms or 4 symptoms or X number of symptoms is the cutoff spot. That has some general utility, but then we know we'll have people who have a fewer number of symptoms, but maybe those symptoms are more severely impaired, or maybe they have few symptoms that maybe aren't even as extremely impaired, but they're symptoms that are important for that individual's life and job. So I think a dimensional approach is more accurately reflecting what's out there. So the other question is, is depression on a dimension? So one is there's clearly within depression, there's a spectrum of severity. Some people are so impaired they literally aren't getting out of bed, they aren't washing, they aren't socializing, they kill themselves. There's other people who have a lower grade dysphoria, everything's negative, some of those physical symptoms, but can force themselves to get out of bed and go to work and do X, Y, or Z. So within depression, there's a range of severity, but does depression really blend in with normal sadness? I would argue we have some good evidence, no, that there's certain categorical aspects of how pervasively one views everything else in their life when one is depressed, and not just whatever might have been contributing to their depression, that there's a more great likelihood for impairment in motivation and all sorts of other realms of life, again, outside of specific symptom clusters. And yeah, so I think the spectrum concept makes things much more nuanced and makes it harder. And in our modern world, I think there's increasing pressure to get quick diagnoses and answers. I think the other big advancement eventually will be much more computerized monitoring of aspects of physical behavior. So how quickly you're typing or you're responding, or where your eye gaze is going when you're saying one thing or another, or the speed of voice or the pitch of voice or the variation between, or the word choice. You can do linguistic analyses. I think there'll be much more computer assisted diagnostic tools to sort out what's going on between different groups of people and what is going on to make a person differ from their baseline, that are going to be important diagnostic information. So Max is asking, do I know of any colleagues, or have I myself been part of any of these APA committees to revise the DSM? Are they usually fair and balanced? So as Fox News teaches us, fair and balanced is in the mind of the beholder. So no, I have not been on any of these committees. I do have acquaintances. I would not say I don't. I don't think I know any good friends who are on. Actually, I probably do know one who's on an OCD committee. I'd say I do think they. So one, it gets back to the DSM is often labeled as a Bible, that this is the word of the great authorities and this is the way it is and you need to follow it and listen. I mean, it is a huge cash cow for the American Psychiatric Association. They get a huge chunk of money from licensing the rights to it. So there's a conflict of interest potentially there. But I do genuinely think that they view it as an atlas rather than a Bible. And by that, I mean, it's a collection of roadmaps. It's issued with the understanding our knowledge of the geography of the brain or behavior is limited. It's like the old maps at the edge of the map, there may be dragons here. It acknowledges that there are limitations to what we know and that hopefully we will learn more, and that part of the scientific process is learning and revising and incorporating new knowledge. And part of the whole rationale for the DSM, the S stands for statistical. This is trying to incorporate scientific purposes. Now, so I think they really try to select people with a range of viewpoints. They try to select people who have an established track record of doing good and rigorous research on the subjects that are involved. And they do allow input for people who have dissenting points of view to address their objections or comments to the committee. And they do try to have independent committees evaluate the work of what the initiating or proposing committees do. So I think, to my mind, Those are all good basic principles of scientific approaches. So I see it's close to an hour, so I'll try to answer the questions that are here, or maybe defer them depending on what they are. And then I will be back next week, every Tuesday, this same time. And again, the subreddit is an option out there for those who want to go into more lengthy discussions, conversations about ADHD topics. So James Alexander, when starting a medication, switching medications and titrating up in dosage, is it advisable to avoid simultaneously starting supplements for vitamins and mineral deficiencies? I would say, again, this is a recommendation, such as vitamin D, magnesium, zinc. My rule of thumb, and I see it so often violated, I mean, if you are in an extreme suicidal emergency or crisis, or maybe you are being hospitalized and there's an absolute need to get immediate results, that's about the only situation I can think of where it makes any sense at all to start two things at once. Because everyone's an individual, everyone has individual reactions, good and bad. If you start one thing, then you have, and everyone has day-to-day fluctuations. If you start one thing, then it's fair and reasonable to attribute what's going on to that thing. It might not be. A panic attack could be triggered by any number of different things. But if you start two things, even if one is usually associated with side effect X or Y, you introduce the possibility that it's the other substance at fault, or maybe just the interaction of the two, and the first one alone wouldn't have caused that problem for you. And that goes for if you really think supplements are going to be doing something meaningful, then you should treat them as if they're meaningful and not simultaneously start things. So I was going to make a joke or two about Trump derangement syndrome and April Fools, and partly, so this is the last question, that people have suggested that I am showing Trump derangement syndrome by even responding to it, because the people who proposed it clearly are joking and don't take it seriously. I would argue that if you really think the world is going to hell, which is what the MAGA philosophy is, and that we need to do drastic things to the government to change it, then introducing a law about TDS, has to be a reflection that they think this is serious enough and worthy enough to be considered. That, to me, does itself sound like an April Fool's joke. Anyway, I will try to shy away from direct political content, but so much of politics is intimately wrapped up in mental health at this point in time. So you cannot separate them. They are inseparable. And I'm aware that I will lose some followers because they disagree with me on some things. But again, even with the politics, I'm trying to stick with what is verifiably true. And, we can agree that has there been some government waste? We can have valid discussions about what is the optimal size of a government, or how much of a safety net should be provided. What's going on right now goes so far beyond that, and I'll leave it at that. So stay healthy, stay happy, take the dose of media that works for you right now, and I will be back next week. And as Max has pointed out, it was a great set of questions. I appreciate you being here, and I will try to work my way back to some of the topics like paracetam and nootropics. That's all. Bye.